Good evening, everyone. Welcome to the Metropolis webinar series. Today, our topic of discussion will be delivering precision oncology to breast cancer patients from principles to practice. Um, I just want to just give you a few instructions that once the webinar is completed or during the webinar, you can, as you see, there's a green button over here which says ask questions. So you can click on this button and a box will appear on the left hand side. If you can see, you can type in your question and then send it. We will receive these questions, and at the end of the webinar, we'll read them out to the panelists. You can also mention if you are addressing the question to a specific panelist. So this is just a bit of housekeeping. I will now move on to introducing our speaker and panelists for today. We have with us our esteemed speaker and moderator, Dr. Bobin Thomas. Dr. Thomas is a senior consultant in medical oncology at the Caritas Cancer Institute. He has been affiliated with previously he's the founder secretary of Trivandrum Oncology Club and founder secretary AMPOK Association of Medical and Pediatric Oncologists of Kerala. Dr. Thomas did his DNB in medical oncology and he has been a fellow pediatric oncology at Tata Memorial Hospital. So Dr. Thomas will be our main speaker and moderator. Our panelists for today are Dr. Archit Joshi. Dr. Joshi is consultant medical oncology and hemato-oncology at Zydus Hospital, Vadodara. Dr. Joshi received his MBBS degree from Baroda Medical College. He did his MD from Savai Mansingh Medical College, Jaipur. He has a DM in oncology from Cancer Institute at Adyar. He also has European certification in medical oncology, ECMO. His past associations have been with All India Institute of Medical Sciences. He has been an assistant professor and senior resident at Cancer Institute, WIA Chennai, and he's been involved in private practices at various hospitals in Baroda. Next next panelist is Dr. Umesh Das. Dr. Das is also a medical oncologist. He is MBBS MD General Medicine, DM Medical Oncology, and practices at Nem Care Hospital, Guwahati. Dr. Das did his MBBS and MD in General Medicine from RML, New Delhi. He also completed a DM in Medical Oncology from All India Institute of Medical Sciences, New Delhi. He has participated in research work in various workshops under the Medical Oncology Department and published many papers. His interests are mainly in breast cancer, cutaneous lymphoma, endocrine cancer, gastrointestinal oncology, and genitourinary and gynecological cancers. Our next panelist is Dr. Srinath Bharadwaj. He's a consultant medical oncologist, MBBS MD DM. Dr. Srinath Bharadwaj has over 10 years of experience as a medical oncologist, and he currently practices at Apollo Hospitals, Jubilee Hills, Hyderabad. He has expertise to treat a wide range of conditions like breast cancer, lung cancer, cholangiocarcinoma, hairy cell leukemia, ovarian cysts, acute ALL, and more. Our final panelist for today will be Dr. Pinaki Mahato. He's MD-DM. He's a consultant in medical oncology, and he currently practices at HCG Cancer Center, Vadodara. Dr. Mahato's expertise lies in head and neck, breast, lung, GI, and gynec and pediatric solid malignancies. Dr. Mahato is also trained in bone marrow transplantation and is an expert in treating various hematological disorders. Dr. Mahato has handled over 25,000 cases so far. With that, I hand over the dais to Dr. Thomas. So you may proceed.
Yeah. Thank you, Metropolis, for this opportunity. I think like today we're having a pan-India presentation. So pan-India representation is there. I'm speaking from Trivandrum, and I can say my panel members are from Guwahati, Jaipur, Vadodara, and Hyderabad. So it means that the entire country has been represented. So I should congratulate Metropolis for that thing, for making it a pan-India kind of a thing. You know, whether it was done knowingly or it happened unknowingly, but then it's actually a good thing to have. Let me share this. Yeah. I hope my slides are visible. Hello?
Yes, sir, it's visible.
Oh, okay. So the next half an hour or so, we'll be discussing about precision oncology and how precision oncology has changed the way in which we are managing the modern medical oncology. Today's topic is restricted to the management of metastatic breast cancer. So we'll be restricting it only to metastatic breast cancer. How precision oncology is taking it forward. So how the treatment has been, how the treatment practices has evolved in the management of metastatic breast cancer. So we know that even now, despite all the awareness activities which we are conducting across the country in almost all platforms, 2.8%, it's like almost one fourth of and we know that the stage 4 disease is practically incurable disease, and the median and coming to survival, the median progression free survival is about 14.2 months, and the overall survival is about 13 months. And the site of metastasis, we all know that it could be visceral, it could be bone alone, it could be a lymph nodal metastasis, it could be brain, or it could be other sites of disease. So this is about the statistics. The statistics says that the breast cancer as of now, it constitutes about 13% of all the cancers in our country. And if you go by the stage, as I mentioned, it varies from some studies says that about 25% of the patients are diagnosed at the 4th stage. But there are some hospital-based trace are there, which shows that 10% of the patients are metastatic. There could be a regional variations in that thing. But on the whole, we know that about 10 or 25%, at least about around 20-25% are in the stage 4 disease. And the pattern of diseases is almost the same: triple negative, HER2 positive, ER hormone receptor positive. The pattern almost remains the same across the country. So traditionally, we know that breast cancer, we used to classify them into luminal A, luminal B, HER2 type, or the HER2 enriched, or the triple negative, or the basal type. And then standard platforms, standard algorithms are there for the management of this particular cancer. So I'm not going into details of all these things. There are standard protocols laid on by several national as well as international associations. So I would like to highlight here is that breast cancer management, cancer is a heterogeneous disease, but metastatic breast cancer is also a heterogeneous disease. We know that the pattern of disease is extremely different with the metastatic pattern. Some patients, they can present with a very small primary and very extensive metastasis. On the other hand, there will be other group of patients who will be having very large primary with very minimal or no metastasis. And even the metastatic population, it's actually different. Some patients with metastatic disease, they live for years or sometimes decades together, whereas on the other side, there are some patients with metastatic disease who succumb to the disease very fast. So it's a very heterogeneous population which we are actually dealing with. We know that there are several genetic and epigenetic changes are involved in the primary side, the metastatic sites. The tumor microenvironment plays a significant role, and it depends upon the tumor biology whether the patient will be able to achieve a remission and the patient will be able to have a long-term result or not. Traditionally, when we speak about breast cancer, we know that there is a discordance as far as the IHC is concerned from the primary as well as the metastatic disease. So we know that previously we never used to do biopsy of the metastatic site, but later on we realized that 25 to 30% of the patients, there is a discordance between the primary site and the metastatic site. So initially the hormone receptor patients become negative, or the negative patients become positive. Triple negative, they started expressing either hormone positivity or HER2 positivity, and vice versa. So nowadays we know that all patients are metastatic. If it is a metastatic site, that the tumor biology is different to make sure that the proper treatment is given. But now we know that there is genomic alterations in metastatic breast cancer is different from the primary site. So primary site, if you do a genomic analysis, and if you do a genomic analysis from the metastatic site, studies, there are multiple studies which has been reported in the literature, which says that there is a discordance in the genomic alterations in the primary as well as the metastatic site. So this is very important as far as the modern oncology or the precision oncology is concerned. We cannot rely on the fact that, okay, just because we did a test upfront, that the cancer is going to behave the same way subsequently. That's not the case. We need to ensure that a repeat biopsy has to be done. And previously it used to be the IHC test. Now we are in the era where we need to do the molecular biology if possible, or preferentially to ensure that the molecular level, the cancer is a different cancer is different at the primary and metastatic site. So I'd like to emphasize here is that, but even just because we identify a mutation, that does not mean that we will be able to target those mutations, because the actionability of the mutations, it varies from primary or to it varies from the type of the mutations which has been identified. So these are some of the regulatory signals which we know. We have EGFR mutated disease, is the HER2 positivity, or could be VEGF positivity, or IGFR positivity, or enriched or mutated diseases are being reported. So these are the validated biomarkers for these are the basic things. So I'm not going into not spending much time. It could be a estrogen receptor, one of the earlier biomarker to be identified. We still rely upon the IHC. Then we have the PR positivity. Very rare if the PR positivity, we prognosticate the patient. Then we know that we are aware of the HER2. We use tests like IHC or the FISH test. Then we have the Ki-67, which helps us to identify the proliferation index, that helps us to determine the aggressiveness of the tumor. Then we have the molecular classifications of the disease. Then we have the MAM test like the MAMAPRIN, Oncotype DX, which does the genomic profile of the patient, which helps to identify, which helps to prognosticate whether the patient benefits out of chemotherapy or not. And then we have the BRCA mutations which have been identified, and of course we cannot forget the PDL1 which we used, and if positive we know about the immunotherapy part. So not all mutations are same, which we had discussed earlier. The clinical actionability for any malignancy, it is classified about the SCAT classification. So SCAT is a molecular, SCAT ranks the molecular target into 6 different classes based upon the clinical indications of actionability in specific cancer type, so that it helps the clinicians in making the therapeutic decision. So the mutations can be classified into tier 1 to tier 4, depending upon the type of mutation that has been identified in the particular patient. So these are some of the approved targets which we use. If you have estrogen receptor, there are drugs from to the modern era of oral SERDs, which about HER2 positivity. We had trastuzumab, and now we are in the era of TDXD, and several new molecules are there in the pipeline. If a germline mutation is positive, BRCA is positive, we have olaparib. If the PIK3, we have alpelisib. We have immunotherapy, we have tislelizumab, pembrolizumab. If MSI, we have pembrolizumab. And depends upon the type of mutations we have, depending upon the biomarker which has been identified, there are a number of molecules are there that can be molecules are available which can be used to target those particular biomarker. So the first study which we are having, this is a 69-year-old lady. She had metastatic breast cancer, and it was ER positive disease. So she was started on an aromatase inhibitor plus a CDK4 inhibitor, and then the disease progressed. We know that the average PFS which we see in about 1.5 to 2 years. So as expected, the disease progressed after about 2 years. So the patient is not in visceral crisis, and the patient is having a very good performance status. So I'd like to ask my panel members, Dr. Archit. So what will be the treatment option that can be offered to this patient? The patient is not in visceral crisis. In your practice, what will you be doing?
So in this case, I would like to send NGS specifically to see the mutations. ESR1, PIK3CA, AKT1, these mutations can be targeted. So I will look for this if then any of these mutations are present or not.
Okay, that's good enough. Dr. Umesh, has it become a routine practice where you start at first progression itself? I know the theory part is there. It says that, okay. Just want to ask from a very practical point of view. Have you started doing it in your day-to-day routine practice, Dr. Umesh?
No. Maximum I am doing PIK3 mutation. If positive, then I send to LPCP. Otherwise, it's really very difficult to do.
Okay, so it means that you are not doing an not an NGS. So I mean that we are not doing it on a routine basis, but on a selected basis.
Yeah, yeah.
Not an NGS, but you will be selecting for specific mutations are being done. Okay. Srinath, any difference?
Sir, agree, sir. Of course, the problem comes
Srinath is
when.
there?
Yes, sir. I'm here, sir. Am I audible, sir?
Yeah, I can. Yeah, you're audible.
Agree, sir. Definitely, if there is a mutation in the PIK3CA, P10 or AKT, yes, I mean, we do have targeted therapies. The problem comes when everything is negative. So we will have to choose a
Okay.
good partner with fulvestrant. And we do have some data of
Okay.
switching the CDK4 with fulvestrant. So that's one point I would like to
Okay.
emphasize differently from what my colleagues have just elucidated.
Okay. So yeah, understood. Yeah. So traditionally, what we used to do was that we used to start the patient on fulvestrant, or if the patient cannot do, we know that we may start the patient on chemotherapy. And there are people who have tried tamoxifen with everolimus. That's a way. But then now things are changing. So we started doing an NGS at least on a selected basis, or depend. We at least we give the options to the patients, and if they are willing, we do the NGS testing. So for this patient, an NGS was done. It picked up this both ESR1 as well as the FGFR. So this was the mutations that were identified. So my first issue is like, how frequently are we testing this ESR mutation? Dr. Pinaki, I think we already discussed that part. So are we doing it on a daily basis, or only on a selected basis? Dr. Pinaki?
So look, metastatic hormone positive receptor MBC, the guidelines are pretty straightforward, and our practice has not really changed in that way for a long time. In a metastatic setting, what I generally do, I send a somatic HRR, I send a PIK3SR1 and a P10 or AKT1. These are, I think, some of the markers that we know that are actionable. Whether to do these markers when the patient presents with MBC per se, or to do them when a patient has a progression on the first line therapy, because we know that the first line therapy consists of a AI plus CDK4/6 inhibitor. So many times we would not do it, rather we would do it when the patient comes with a progression to an AI plus CDK4/6. We know that ESR1 is an acquired mutation, especially when you treat the patient with an AI, you get this as a resistance mutation. And therefore, because we are having some drugs that we can use, definitely we can't continue the AI, we should switch to fulvestrant. There is some data to switch the CDK4/6 inhibitor as well. We have data with ribo and fulvestrant, and we have seen that around 5 to 6 months of PFS you can get by that.
We are coming to that thing subsequent. So there are the answer to this question is like, ESR1 mutations are detected in about 20 to 40% of HR positive, HER2 negative metastatic breast cancer, and this is the most frequently detected mutation that has been identified. So my question to Dr. Srinath is that if you decided to do the biopsy, what sample do we test? Are you happy with doing a biopsy, or have you started practicing liquid biopsies, ctDNA?
Very comfortable in doing a biopsy if the lesion is targetable, sir, because that gives us the most reliable data. But of course, PIK3CA mutations, the liquid biopsy is already FDA approved. So I think we're not wrong in doing a liquid biopsy if we have only bone only mets and the biopsy is not quite possible. I mean, so even when I bone only mets, few of the aggressive intervention radiologists are getting us a biopsy, but if we think there will be really destabilization of the spine or something like that, we'll always go for a liquid biopsy. We're not wrong in doing it.
Yeah, that's good enough. There are studies which shows that when you're doing a liquid biopsy, the chances of the better tumor heterogeneity capture is important. That's very important, because if you're doing a biopsy, we may that the heterogeneity will not be able to pick it up. And then there are multiple studies have shown that there is more than 90% concordance with the tissue NGS. So the other issue is like, if we are planning to do a ctDNA, have you started doing it in a longitudinal ctDNA? Do you feel that it helps in the treatment decision, or you are happy with one biopsy and then you just wait for the clinical progression? Dr. Umesh?
Yeah, if CT diagnosis, CTDN, liquid biopsy showing ECRS1 is mutation, then we have to sense the treatment.
Okay, fair, good enough. So the studies have shown that if you're doing it, it's better to do it on a serial basis because it helps to identify the early resistance detection can be identified so that will helps us for the treatment optimization. The other issue when we come to this doing this liquid do the biopsy is that the VIF or the variant allele frequency. So do you feel that any percentage of VIF is significant or you ignore that thing? Dr. Archit?
Certain level of EF levels we should ignore and we can continue with the same treatment what is going on. But not sure about what should be the cutoff for this.
Yeah, I feel like this is not a clinician question. It should be asked to the molecular biologist. But studies, what they mentioned about 70% of the mutations occur at BIF under 1.2%, with 40% at BIF less than 0.5%. So they say like BIF levels should not influence the treatment decisions with SR1 targeted therapies based on the current evidence. So irrespective of the BIF, we should be starting the patient or we should be targeting the mutation.
Dr. Thomas, what we should be looking at in a liquid biopsy is the tumor fraction. If you have a
Yeah,
tumor fraction that is more than 1%, then I think any WAF is fine. But if the
yeah.
tumor fraction is very low, then it becomes questionable whether this is actually a clinically significant value.
Right, agree to that. Yeah. So there are people who feel that okay, if you're doing an ESR1 mutation, if you do the WAF dynamics, whether it is increases or decrease, the real-time monitoring is it predictable for resistance? Yeah, you can answer, Dr. Pinaki.
I'm not really sure about this, but generally what we would do is wait for the macroscopic progression to happen. Definitely, I think there will be data where saying because the VF already in a liquid biopsy is going to be very low. We are not really sure. So I
Yeah.
would not really rely on this thing for monitoring my resistance.
Okay. That's from a practical point of view. We still rely upon. We still wait for the delay. Wait for the clinical or the radiological progression. But then it's too early. But then I feel like with the technology becoming more and more easily accessible and more cost effective, I think like this might become a practice. So what about this? Sometimes we come across this co-mutations where ESR1 and TP53 will be there. So you feel that this will predict the resistance to the subsequent treatment?
It is
Dr.
logical
Singh?
because you have got other mechanisms of resistance, although we don't change our treatment based on
Yeah.
these mutations as of now.
Yeah, TP53, we know that it's a very commonly identified mutation. So they say like just because TP53 is not we should not change, but then there are subgroup of patients are there who don't respond as expected to the traditional treatment. So yes, it's a co-mutations can occur. It's in about 15 to 30%. So there could be a different modifications is required. And they say like SR1 and P53 are mutually exclusivity is there. But since we're not doing it very on a routine basis, yet to encounter all the situations. So this is the molecular pathway. We know that it leads to the active confirmation in the absence of a ligand, decreasing the affinity of ligands, including estrogen, SERM, or SCRD. So if it is mutated, the conventional estrogens or the SERMs or SERD, all those things does not work. So we need to ensure that we need to treat the patient at a different level. So the standard drug, we know that the conventional anti-estrogen drugs like estrogen, letrozole, exemestane, fulvestrant, all these things, tamoxifen, all these things will not work if the ESR is mutated. We have to go for the newer drug like elacestrant. If it is turned out to be an FGFR positivity, as of now, we don't have the many drugs. Options are currently not available with us. So we rely upon the drugs which we use in other indications like sunitinib, pazopanib, or the other fitimatinib, which is not available. But sunitinib and pazopanib are the drugs which we routinely use in if at all we encounter all these things. These are all we know that these are all off-label indications for us. So coming to the studies, Emerald, it's a phase 3 study which was
I think sir has left due to the poor internet. Let's wait for to rejoin sir again.
I think there is some issue with the network. Now it's clear, I think. So the takeaway message is that elasticent is the first oral selective estrogen receptor degrader that's demonstrated a progression improvement versus standard of care both in the overall population as well as in the patients with ESR mutation with manageable safety phase 3 trial of patients. So the other study which we'll be discussing is the Serena 6 study. It enrolled patients with ER breast cancers. What they did was in the study was that all patients underwent ctDNA testing every 2 to 3 months to monitor for the emergence of ESR1 mutations coinciding with the routine imaging. If an ESR1 mutation was
Excuse me,
detected,
sir. Excuse me. Dr. Thomas, please, can you share your screen?
oh, it's not okay.
Yeah. And sir, I think it would help if you just turn off your video. Sometimes that helps with the connection.
Yeah, my video is on.
No, if you turn it off, I mean, I think, yeah.
Hopefully. Is it visible now?
Yes. It's
Yes,
visible.
Sir, are you sitting near to the internet?
Pardon?
So, are you sitting near to the internet because the internet is getting disrupted?
Yeah, there is some issue which it's rains.
Yeah, but
so
now it's coming. Now the voice is coming clear.
Okay, okay.
So you can continue, sir. Yeah.
Okay. So if an ESR1 mutation was detected and the patient had no radiological disease progression, patient was randomized into 1:1 to either switch to an AI or to a chemicistran, and while continuing their current CDK4/6 inhibitor or to continue with their existing drug, and both arms included.
Sir, again the voice is getting disturbed.
That there was a significant improvement in the group of patients who had a chemistry.
Sir, we can't hear you.
Am I audible now?
No, sir. It's still the voice is breaking. If you can sit near the Wi-Fi, maybe it works.
Can you just hold? I just reconnect with a different network. Is it audible now or still same issue?
Yeah.
So now it's audible.
Okay, okay. So the study showed that the median PFS was 16 months with the study arm versus 9.2 months with the AAA. With the aromatase inhibitor. So this was the study that showed that, okay, the serial monitoring of ctDNA definitely helps as far as the disease early intervention is concerned. So the take-home points from the first study is that camizestrant plus CDK4/6 inhibitors have nearly doubled the progression-free survival compared to continuing AA with the CDK4/6 inhibitor. ctDNA surveillance enabled early intervention detecting ESR1 mutations before clinical progression. So we are able to identify the group of patients who are going to progress much upfront, and then changing the treatment definitely helps them. The PFS was benefit was durable. It was 29.9 versus 5.4 percentage. PFS2 outcomes support long-term benefit with early therapeutic switch, and the safety and tolerability was favorable with low rates of discontinuation. So Serena 6 is the first phase 3 trial to validate ctDNA as a clinical decision-making tool in metastatic breast cancer. So coming to the second case, this was a 42-year-old lady, ER positivity, HER2 negative disease. She received anthracyclines and taxanes upfront. That means that the tumor burden would have been very high, or the patient would have been in visceral crisis. So the disease progressed. So in this situation, what will be the treatment option? Dr. Srinath, you will switch on to a different chemotherapy, or you will be happy with to do a mutation, ER positive, HER2 negative disease.
Sorry, I just missed out. Is she in visual crisis, sir? I mean,
ER positivity, HER2 positive, ER positive, HER2 negative disease, received anthracyclines and taxanes upfront. Patient had a large volume metastatic disease, but after that patient progressed on chemotherapy. So what will be your approach in those group of patients? You'll be happy with to start on a different chemotherapy, or you start looking for a mutation?
no, sir. I'll directly go for CDK4 and letrozole combination. If
So if that has not been exposed upfront, okay.
Yeah.
Other panel, yeah.
Yes.
Other panel members, any change in difference of opinion?
Still, hormone positive and HER2 negative, the same 646 plus AI can be offered. We'll check for germline BRCA mutation also here.
Okay.
Yeah. In the meantime, we send for markers and start immediately CDK4 inhibitors and AI.
Okay, yeah, that's one which we practice, which we all do routine. So for this patient, they did an NGS was done. So PIK3R1, the two variants were identified. PIK3R1, as you can see, two variants were identified. Also, the tumor mutation burden was 12.2. So how do you proceed with this patient? So patient had a PIK3R1 as well as the tumor mutation burden. Dr. Archit?
So this patient has shown PIK3 mutation. Then I think the combination fulvestrant plus alpelisib can be offered. That particularly works on this mutation.
Actually, this is first line hormone therapy. I think we should not give it. Reserve it for second line.
Yeah, this is for alpelisib plus fulvestrant is for second line.
Okay. So this patient, while both we know that there are two PIK3s, are the PIK3CA and PIK3R1 mutations both can activate the PIK3 pathway. PIK3 mutations involve the gain of function changes. The subunit mainly there is loss of inhibition. So for sake of discussions, we are taking we'll carry on with the PIK3C 3A inhibitor. So we mentioned, like, when we had the earlier discussion, it was mentioned that people have started doing this PIK3 mutations upfront. So is it the routine practice, or you do it only at the mutation, Dr. Pinaki?
I think we should do it. This is an early, unlike ESR1, this is an early mutation. We should be doing it when it comes with metastatic.
Okay, so it's better that we start doing this mutation very much upfront itself, so that the treatment decisions can be made, the options can be discussed with the patient. So if you're depending upon what type of testing we'll be doing, are you happy doing a companion diagnostics, or you ask for a CGP, so that we want to look for the type of mutation, anything specific, or you look for that entire panel you'll be sending?
As of now, not the CGP. We are doing the PIK3C. I don't know what, but generally Novartis, they used to do that companion diagnostic kit, so we used to use that one.
Okay. So CGP studies show that superior to companion diagnostics alone for full spectrum of PIK3 alterations. They use CGP as first line approach when available with companion diagnostics as an acceptable alternative. But then the practice changes depending upon where you are practicing and also the scenario. So when we get an NGS report, it's showing that a PIK3 mutation. So what is your first thought? Do you think that it is a targetable driver or a prognostic marker, Dr. Srinath? Hello?
Sir, sorry. Sorry, sir. I just missed the question. There was an internet delay.
Okay. So you feel that if when we get an NGS result and the PIK3 mutation is identified, what do you feel that is a targetable thing or a prognostic marker? So how do you think about that thing? How do you take
Uh,
that information?
Targetable thing, sir. But in first line, I think the data is still for CDK4/6 inhibitors compared to PIK3CA inhibitors. Second line, definitely, we do have both alpelisib or capivasertib as options.
Okay. The VIF part, do you think that the VIF needs to be addressed in this situation as well, just like we do it for ESR1? Umesh?
Yeah, I'm not sure.
Not sure. Yeah. That's what
Yeah,
we need to discuss this part
we
with the
need to discuss actually
Yeah.
with molecular biologists. This one.
Yeah, as a clinician, we are not very familiar with this VIF,
Yeah,
whether it is relevant or not. So, on a case by case basis, when it come across all these things, we need to
yeah.
discuss with the molecular oncologist. That's the relevance of the molecular tumor boards, which we are happening across the country right now. Just because the mutation has been identified, that does not mean that we will be able to target that mutation or not. That is the issue which we are facing
Yeah.
currently.
Sir, I think if I may interfere,
Yeah.
I'm sorry, but usually if it is a known mutation, let us say EGFR in lung cancer or PIK3CA in breast cancer, WAF of 1% I think should be a decent cutoff, sir, more than or equal to 1. If it is not really a known mutation, then maybe at least a cutoff of 20% is what we expect to really consider it as a driver mutation.
Okay.
So that has been the data, sir.
Yeah, I think like it's better to have a discussion with the molecular team before having the final decision, because there could be a variance of unknown significance. We are not sure as a clinician. Our knowledge about molecular oncology is very still in the very early stage. So we need to discuss
Absolutely.
this part
Absolutely.
with the clinician with the molecular oncologist.
Yes.
So this is the standard pathways which we routinely pathway. I'm not going into the details because all of us are familiar. So if a patient harboring both ESR1 and PIK3 mutation, so how do we sequence? Do you feel like an oral SCRD should be given or a PIK3CA mutated should be introduced upfront? So what do you feel, Dr. Archit?
Dr. Archit has left, sir. Uh,
Dr.
I mean,
Pinaki?
yeah,
Can
so
you?
we should look at the PFS that we get with the either a PIK3 or SCRD. So whichever gives a higher PFS, I think that should be the first preference to use. I think mostly I think is a PSR1 mutation. I think that would be used first. The other problem with the PIK3 is that many times our patients would have PIK3CA mutation, but the drug is very toxic. So we try to reserve that drug for a later line of therapy and rather use the less toxic versions first.
Okay, I feel that okay. Rather than using everything upfront, we should reserve the drugs for subsequent usages or the more toxic drugs or the drugs which we are not very that familiarly using, frequently using, or which we are not that familiar with, that can be used at the later stage.
So
So,
if I may, I had a similar patient, sir,
yeah,
and I used a combination of both capivasertib and elacestrant. The combination being tolerable, but my patient had ER 3 by 8 or 4 by 8, but had both the mutations on NGS, and the PR was negative. So the response was not that great. The PFS was only 6 months. I thought that is because of the lesser ER percentage. But if you have a good, strong hormone positive lady, I think the combination is quite tolerable. So that's what I understood. The toxicity is tolerable of the
okay,
combination of both capivasertib and elacestrant.
okay. I mean, I don't have any experience of using that particular combination till now, so I'm not able to comment on that thing. But then, if your experience says that, okay, I feel that, okay, I mean, these are all the learning, we are all in the learning phase as far as these new molecules are concerned. So, how to whether should we use them independently or should we combine them? Is there a difference in the toxicities? All these things in the coming years, we will be able to get a better idea into that. So, do you feel that, oh, okay, I think we have discussed that thing. So in the situations, if we don't have the other drugs or the newer molecules, we have to still rely upon the traditional drugs like either everolimus or temsirolimus or the other drugs or the alpelisib if there is a PIK3, or we can use the different what do you call it? The conventional mTOR inhibitors can be used, or the newer drugs like the alpelisib or the capivasertinib can be used for this group of patients. So here comes the Innovo 120 study. It was a phase 3 study that evaluated imatinib when combined with palbociclib and fulvestrant versus placebo plus palbo plus fulvestrant in patients with PIK3CA mutated hormone receptor positive HER2 negative metastatic breast cancer. And the initial analysis showed a statistically significant improvement in the progression-free survival, but then overall survival data was not yet mature. So the initial data is, you can see that the final data is about they came last year in November 2024. It showed that there is a median overall survival was 34 months versus 27 months. The overall benefit was consistent across all key subgroup, and the overall response rate markedly improved with the Innovo AM. It was 62.7% versus 28%. So this is a new molecule which can be explored in this particular scenario. And the final analysis from the Innova 120 study states that adding this, the drug to palbociclib, there was a statistically significant and clinically meaningful overall survival advantage for patients with PIK3CA mutated breast cancer. The regimen also significantly delays progression and the need for chemotherapy, and the drug was very well tolerable profile over a extended treatment period. So now coming to the third case, it is about a male breast cancer patient. Is a 59-year-old male patient who presented with a large discharge from the left breast mass, and axillary lymph node was there. He had a poorly controlled diabetes. He used to smoke. There was no family history of any malignancies. Physical examination, there was a large mass, erythematous ulcerated mass, 9 into 5 centimeter. I don't know how a male patient can have a 9 into 5 centimeter mass in the subaerial region. Most have ignored. Tumor markers, everything is well within the normal limit. So the patient underwent a radical mastectomy. It's turned out to be a stage 3 disease, PT4B N1 M0, ER positivity, a triple positive disease. So how do you treat this patient? So you treat just like a female patient with breast cancer, or do you feel that this group of patient needs to be managed in a different way? Dr. Umesh? Umesh left it.
We have to treat the patient like I'm there. Yeah, we'll treat like same like female breast cancer only.
Okay. Yeah, we have not much of studies have done on male breast cancer. So whatever cases we come across, we tend to extrapolate from the female breast cancer. Whatever treatment is there, just like the female breast cancer. Are we doing the correct thing in that scenario? We are not, but then that is the practice. The only thing is that will you be sending this for a germline BRCA mutation, Dr. Archit?
Dr. Archit has an emergency and he
Okay.
had to leave. So maybe you
Okay,
can.
Dr. Pinaki, you can.
So what I feel how male breast cancer is different is generally male breast cancer is going to be more aggressive. You have got a smaller breast and therefore there is a higher propensity of this disease to spread. So even in early breast cancer patients, this was a locally advanced disease. But I would treat these patients with chemotherapy. Generally, that is my practice. Definitely, universal genetic testing for a male breast cancer is very important. This patient actually has a HER2 receptor positive disease as well. And we have seen that traditionally those patients probably don't have that germline mutation, but then still it is worthwhile to see because
Worthwhile attending that.
yeah, it should worthwhile to see this thing.
Okay, so the importance of we need to check whether the patient has got the BRCA mutations are there. The various guidelines they clearly mentioned that any male patient with breast cancer, we need to do the BRCA mutation. They also are at increased risk of other malignancies, like it could be a prostate cancer, pancreatic cancer. So it helps us to screen the relatives, and if you're able to, we should be able to pick up some other lesions at an early stage. So that's about the male breast cancer. And coming to the fourth case, this was a 40-year-old lady who was diagnosed with breast cancer, breast and ovarian mass she also had. So she had a family history. There is father had leukemia, mother had ovarian cancer, her grandmother had colon cancer. The surgical history, she had previously underwent a laparoscopic cholecystectomy. Do you feel that how frequently do you get breast and ovarian cancer simultaneously, not metastatic disease? Dr. Srinath?
Um, Sir, in the past 8 years, I'm seeing the first case that I'm actually treating it right now.
Okay.
So she has simultaneous ovarian and breast malignancies, IHC proven to be different in origin.
Yeah.
And ovarian disease is stage 3C and breast is T2N0.
Okay.
Hormone positive, HER2 negative.
Okay.
So
And what about Dr. Umesh? Have you seen the scenarios?
No, I have not seen. That's
Okay.
concurrent ovary and breast.
Okay. Dr. Pinaki?
No, sir. Generally, we find that there are Krukenberg mets, but I've not seen two primary malignancies at the same time.
Okay. I've been practicing for the last 15 years. So I just had only one patient in the last 15 years who had a simultaneous breast as well as ovarian cancer. She was a nun sister. She had a breast lump, then she had a ovarian lesion. I felt that okay, it was not looking like a metastatic disease. So it was very difficult to convince her to do biopsy from the ovary because we need to convince her. So finally I managed to convince, and then we did a biopsy, and it turned out to be two separate primaries, and then we treated it separately. Initially I treated the patient for an ovarian cancer, but I thought like I mean, it happened about the patient came to me about 5 years back, and then we treated initially gave with paclitaxel carboplatin and had a very good response, and then the patient underwent surgery for both breast as well as ovarian malignancy. She underwent both the surgery, then she received adriamycin, and it's more than 5 years, and then she is doing good. So this is a very rare scenario, because we need to have we need to think the case when the patient comes to us, we need to have a very open discussion. We need to keep powers, all the options need to be seen, because if we take it as a stage 4 disease, the approach is totally different. And if we take it as a two separate primary, our approach will be different. So I think like among four of us, and Archit is not the, so we only had about two cases in our clinical experience. So this patient had two separate primaries, so both were treated separately. What is the relevance of all these things? So if you are doing these two separate things, so is it giving us anything extra we should be looking into? Dr. Srinath, did you do any mutation panel for that patient?
not yet, sir. She was actually having ascites and all that. So we just started the first weekly chemotherapy. Slowly we have to convince them and go ahead with all the others.
Okay.
Yes.
For the patient whom I was taking care, she was a nun, I mentioned she was a nun sister. For her, I couldn't do the BRCA mutations because that involves many other very other issues which were emerged. So the mutations were not done. So the family members were told to come on regular follow-up. Mutations were not done. But then it's, as I mentioned earlier, she's crossed more than 5 years and she's doing extremely fine. So that could be a mutation that could be done. So for this patient, they underwent a genomic profiling and a pathogenic BRCA1 variant was identified. We know that the HRD score was sequenced using right ovarian cancer sample. HRD was positive with a genomic instability score of 45, and the same mutation detected the germline pathogenic variant previously in the BRCA1 was also identified. So the patient had a potentially significant clinical finding, MYC amplification and TP53, MSI stable, PDL1 was negative. The liquid biopsy was done that could not identify any further biomarkers. So looking into the results, so what do you feel that what should be the approach to the patient? So after finishing the standard treatment for breast and ovary, what kind of a treatment should be offered to this patient? Dr. Pinaki?
So I think considering she has a BRCA1 mutation, we need to give Olaperi for a couple of years. I think that will also cover the breast part as per Olympia.
Okay. Dr. Umesh? Srinath?
Considering the HRD positivity, the best data we have as per if we exactly follow trial verbatim, then Niraparib has the best data in ovary, sir. So, but the combination of breast and ovary, I think olaparib would be a wise choice in view of availability and the combination of the tumors.
Tumors. Okay, yeah. So I think thank you all the panel members. We had a very fruitful discussion. I think we are into the precision oncology. Things are getting more and more complicated. We need to involve the molecular pathologists. We need to have very close discussion. Earlier days, we used to have a close discussion with our pathologists. Nowadays, we need to have a much more closer discussion with the molecular oncologist. That because all this multiple mutations are coming, and even at disease progression, the profile of the mutations keeps on changing. So whether all those mutations are clinically relevant, how to target them, all these things needs to be addressed. So that's the importance of having this molecular tumor boards in the practice of modern medical oncology. So thank you, Metropolis, and thank you, my panel members, for this very active discussion.
Thank you, sir.
Do we have any questions?
No, I don't think we have any questions.
Darshan, do we have
So,
any questions?
we have 2 questions. Just a signal sending in the chat box.
I have shared that questions with Priya Darshini in private chat.
This is yeah. I mean, I think that the first one is not a question really. So I mean, that's the only one I have here.
Okay, then. Okay, I have received the other one.
I think the way forward is to
Okay,
have.
so there is a question from Dr. Ashok, I assume. Does ESR1 mutation increase the risk of cerebral metastases?
Okay, I'm not sure about that thing because the data's the personal experience with the ESR mutations is still very limited. So I'm not sure about that thing. Srinath or Umesh, anybody do you have any experience?
Yeah, all these recent molecular advances very difficult to say actually.
Okay. I think the future with more and more data coming of all these mutations, definitely we will be able to have a better answer to all these questions. Why some patients are behaving in a particular way, or some patients tend to have a particular site of metastasis. Previously, we never used to we didn't know, because there are some diseases are there which metastasize to some particular organs only. There are some disease that spread across multiple organs. So then there might be an underlying reason, but then as of now, we are not sure about that thing. I feel like in the days ahead, with our knowledge about molecular oncology, about precision oncology is improving, we should be able to get more inroads into all these things.
So I believe there are no other questions, right?
Yeah, we are done with the questions.
Yeah, okay. So thank you very much to all the participants who joined our webinar. Thank you, panelists, for being a part of this series. Thank you, Dr. Thomas. Yeah, I mean, I wish you all a very happy weekend, happy Deepavali, yeah, thank you all.
Thank you.
Thank you. Thank you, Metropolis.
Yeah, thank you.
Thank you so much.